Dear students, myself Dr. Muthu Keerthana, working as Assistant Professor in Vinayaga Mission Shankaracharya Dental College, Salem. I am here to present a topic based on immediate complete denture. So moving on to our topic has the contents based on the definition, classification, advantages and disadvantages of immediate dentures and what are the types of the immediate dentures and the summarizing of it and then its references. Moving on to the introduction, the immediate complete denture, it's nothing but it can be given to either a removable partial denture or to the complete denture for the patient who need to restore their teeth and to restore the lost function of the maxilla and mandibular structures, associated structures with that. According to the glossary of prosthodontic terms in 10th edition, immediate denture is defined as any fixed or removable dental prosthesis fabricated for placement immediately following the removal of natural tooth or teeth. So this definition depicts that this immediate denture can be delivered to a single teeth or to a multiple teeth or to the complete denture patients. It can be done for both the kinds of restoring the teeth. And what are the requirements of an immediate complete denture? The common requirements of a complete denture is we have to restore the masticatory efficiency. Similarly, in immediate complete denture also we have to restore the masticatory efficiency, and similarly we have to maintain the remaining supporting tissues, that means either the alveolar structures or the soft tissues. We have to maintain and preserve it. And then by maintaining these masticatory efficiency and the preservation of the tissues, it will be helpful for them to regain their harmony and aesthetics and also will helpful in maintaining their phonetics of a patient. And what are the advantages and disadvantages of doing an immediate complete denture is it can easily maintain a patient's appearance. So the patient will not feel any difference that they have lost their teeth and they need to wait for a 3 months or 2 months or 1 month period of a time. So it will be psychologically supportive for a patient. Similarly, it will give support to the circumoral tissues and the muscle tones, and it will maintain the vertical dimension of an occlusion and the facial height will be restored. And this will be easy for the patient to get adapted to their dentures. As these are the advantages of it, so what are the disadvantages of it? Disadvantages is, for example, if we are removing the anterior teeth, there are possibilities for wearing a anterior ridge undercut. So anterior ridge undercut, so it is very difficult and it may preclude accurately capturing a posteriorly located undercut. So it will have a complication during their retention. So while taking a diagnostic cast itself, we have to analyze, we have to survey the cast, and if it is needed, we have to remove the undercuts in our preclinical works. And next is there are chances for them to attain incorrect centric occlusion positions. They had a chances of inability to accomplish a denture try-in. In a normal complete denture, that means in a conventional complete denture, there are chances for the patients to have a wax try-in and they can have an outlook of it. Whereas in immediate complete denture, they don't get a support like that and immediately they are restoring with their natural teeth, which is mobile teeth. So in that cases, it is very difficult for them to see their denture try-in. And next is it has an increased chair time. Sometimes there are procedures may be difficult and it will require an increase in chair time of the patient. So according to Boucher, the types of immediate denture is it's conventional or classic immediate denture or interim or transitional or non-traditional immediate denture. So what are the differences in these? Conventional immediate denture is nothing but if the patient is having a posterior edentulous for a long period of time, only their anterior teeth is mobile, they have to only replace this thing. In this case, we can go for a conventional immediate denture. As the posterior region is already healed, it is easy for us to give an immediate denture for these kind of patients. So what are the things will happen in a conventional immediate denture after we are delivering a denture? In the sense, after 3 months of period, after the healing has been over, there are chances for us to go for a relining of a denture, and then it will require only 2 extraction visit, and aesthetics probably it will not have a much difference when compared to their natural teeth. So the cost will also be less and the treatment process is not as longer, but since it has a very cost less and it requires very less chair time when compared to the conventional, when compared to interim immediate denture. In interim immediate denture, it is not like a conventional immediate denture, it is a short-term prosthesis. So it is done immediately after the day of extraction. If a patient is having a multiple teeth with their loss of supporting tissues, for example, if they having a very low periodontal support like mobility and furcation involvement, and there are poor chances to retain their teeth, and then the patient is having root stems. In all those cases, if you are willing to restore the teeth immediately, in the sense this interim immediate denture is given for such kind of patients where we will remove all the teeth on a single day and then we will deliver a denture. So after a normal healing period for a denture to be replaced is normally 3 months. But in this interim immediate denture, we don't give much time. On the day of extraction itself, they will be delivered a denture. So in that case, interim immediate denture can be worn by a patient only for 2 months or like that. After a period of time, after the healing has been done, the patient will not have a proper stability, retention and support. In that case, we will go for a second denture. In this interim immediate denture, it is a single extraction visit. It's not like a conventional immediate denture where we have gone for a 2 extraction visit. As I have already mentioned, in conventional immediate denture, already their posterior teeth has been removed. So already an extraction has been done and then only we will be proceeding with their anterior. So it has a 2 extraction visit. Whereas in interim immediate denture, it has only 1 extraction visit. And then we require a second denture. It might be it has a less time, but it requires repeated review for a patient. That is the difference between interim and conventional immediate denture. And moving on for the diagnosis and treatment planning, these are the things we have to look out for it. First one is the local oral conditions and the patient's mental attitude and systemic status and past dental history. In patient's mental attitude, what we are going to see is the best for the immediate denture is a philosophical time. That means the patient should be acceptable for a kind of treatment. So the careful explanation to the patient has to be given with the limitation. Proper limitations also should be explained to the patient. When moving on to a systemic status, if a patient is having any other, because on the day of extraction itself we are giving a denture, so we have to inquire for their systemic status like any hypertension or any other hemorrhagic disorders or any other conditions where they are having a tablets like aspirin or like that. All these things should be inquired from the patient and data should be collected, and based on that only we have to select the patient. In past dental history, we have to inquire a patient whether the patient has already gone for a dental treatment. If they have already gone for a treatment, we have to ask them whether they are having any allergic reaction to the local anesthesia while their extraction has been done. So we have to re-inquire and confirm with that. And moving on to the intraoral examination, what and all we have to do is, first and foremost, we have to make a diagnostic cast. If a patient is willing and they are willing to proceed for the immediate denture, the first and foremost intraoral examination we have to do is, we have to go for a preliminary cast impression and then we have to evaluate the cast. In that cast, what and all we are going to see is, first the condition of the teeth has to be evaluated overall, and then the teeth which has to be extracted has to be marked, and then the position of the teeth and the shape and mold of the existing teeth, because we are going to restore the mobile teeth or the missing teeth in the same area, so that we have to check for the shade or position of the teeth, and then we have to check for their midline, and then we have to check either they are having any diastema or rotations of the teeth, and then we are going to mainly the first and most advantage of doing an immediate complete denture is it will maintain the vertical dimension. So it will restore the vertical dimension of a patient. Then we have to check for their vertical and horizontal overlap. Similarly, these has to be checked in their patient's extraoral examination also. In extraoral examination, we will check the lip support and the position of the lip line and the amount of exposure of the anterior teeth while they are speaking or while they are laughing, and during their movements we will be observing all these things. So next is the location and analysis of the undercut areas. In location and analysis of undercut area, the first and most important disadvantage in immediate denture is anterior ridge undercut. So we have to analyze the undercuts of the cast with the help of a surveyor. What are the things we need to check is the location of an undercut and the depth of the undercut. So minimally, if it is less than 2 mm, no modification is required in the cast. If it is more than 2 mm, a careful study of the cast on the surveyor may reveal a path of insertion for the denture. If it is not feasible enough, we can either go for a horizontal modification or a vertical shortening of a denture flange. In case of severe undercuts, there are no chances for going all the possible above mentioned procedures. We have to go for surgical correction of it. And next is an extraoral examination. As I have already mentioned, the visual and digital examination has to be done. In visual and digital examination, we will see the supporting lip support and their midlines and their lower vertical height of the patient, because we are going to restore the vertical dimension and we are going to restore the harmony of the patients in aesthetics. And moving on to the photographs and radiographs, first and foremost we have to see the intraoral view of the teeth in both the maxilla and mandible, and also we have to see the occlusion of the teeth on both the right and the left side, and display of the posterior teeth in the buccal corridor also should be viewed in the photographs, and the photographs with the lip closed and smiling, and all these actions should be done, and the photographs has to be taken. And then we will take a profile photographs, and in radiographs we will take an ortho OPG. For that we can analyze whether the bone level of the patient is feasible to restore it. And next, moving on to the clinical procedure, the first and foremost step, as I have already mentioned, it is a preliminary impressions and the diagnostic cast. So all these has been explained in the previous slides. And moving on to the next is the custom trays and the final impression and the master cast, and then we will proceed for the jaw relations for the immediate denture, and then we will go for the preclinically we will be setting the denture teeth and verifying the jaw relations, and the patient try-in will not be done in this case. I have mentioned it because we will be doing the patient try-in in case if you are going for a conventional immediate denture. And next in we will be going for the preparation of cast for the surgical templates, and then immediate denture insertion, and then the subsequent service for the immediate dentures. So in case of preliminary impressions, why we need to take a preliminary impression? Because we are here to record the basal seat of the denture and the adjacent anatomical landmarks. And the tray selection should be very important, because the selection of the tray, as the patient is already having a mobile teeth or the teeth will not be supportive while you are making an impression. So we have to go for a tray, extra size tray with that, and then it should be contoured with the carding or the utility wax, because it should not impinge the surrounding tissues. In that case we have to make an impression with the alginate. And then if suppose if a patient is having a very minimal 2 or 3 teeth and their teeth have very mobile enough, so we can use a copper bands over their loose teeth. And in that case there is a modification also. We can modify a plastic stock tray which has we can expose we can cut off the labial or the buccal flanges of the trays, so that it will be helpful for us to record the impression. These are the modification which they have done in a study. And moving on for the custom trays. Custom trays, there are 2 ways of fabricating a custom tray, type A and type B. Type A is nothing but a single full arch custom impression tray. Type B is a 2 tray or a sectional custom tray. So as we have already mentioned, the single full arch custom impression tray is nothing but we will be covering wherever the teeth is there, we will be covering all the area of the teeth portion with a 2 mm wax sheet, and then we will be doing a special tray over it. That is a single full arch impression tray, as this is the single full arch impression tray. And next is the 2 tray or sectional custom tray, is nothing but this picture depicts the sectional or a 2 tray custom impression tray. In the 2 tray or a sectional custom tray is nothing but this method is done only when the posterior teeth have been removed. In that case we will be doing this 2 tray or a sectional custom tray. It's nothing but the posterior portion alone will be separately done with the special tray, and the anterior portion will be given separate. The labial flange of the area anteriorly will be given a special custom tray. It will be like it will work as a sectional special tray. And there is another impression called as a Campna impression tray. It is nothing but it looks like a full arch tray with a hole cut where the remaining anterior teeth are present. So we can use a stock tray over full arch tray captures anterior teeth in the impression. So what are the advantages when using a Campna impression tray? Is nothing but it will have a facility to record the labial vestibules with a more accurate impression, and with the help of either any one of the tray we can make a final impression. And this is the final cast of a immediate denture. After we have done a secondary impression, now we are proceeding with our jaw relation. So we have required our master cast, and after obtaining our master cast we have to adapt the denture base. After the denture base has been adapted, the wax occlusal rim has to be placed over the record base, and these occlusal rims are tried for the patient comfort. This picture depicts the immediate denture for a conventional immediate denture patients. In this case we can able to retain the existing vertical dimension of the patient, and after recording the jaw relation we have to transfer, we have to do a face bow transfer, and centric relation has to be recorded, and this has to be mounted in our articulator. And then we have to go for the posterior teeth arrangement. Appropriate posterior teeth has to be selected, and based on the centric relation and the vertical dimension, the teeth has to be arranged, and the wax try-in for the posterior teeth alone has to be checked for the patient to verify their centric relation. And the midline of the, after our centric relation has been recorded, the midline of the newly selected midline is recorded on the land area of the master cast. This has to be done after the jaw relation. In this, the anterior plane of occlusion, that is the interpupillary line which is acting as a guiding line, is determined and marked on the cast, and the two teeth should preferably be found that are parallel to the desired anterior plane of occlusion. The cast and the land area are marked with all the information gathered, which includes the pocket depth, free gingival margin, a line marking the interproximal of each tooth. Moving on to the preparation of the cast and the arrangement of the anterior teeth. In this, we have to do the whichever teeth we are going to replace, we are going to remove the teeth with the disc. This can be used with a suitable trimmer so that it can maintain the labial aspect of the teeth. So while removing the teeth over the cast, we have to be very careful enough that we are not going to remove the excess bone in it, because if you are doing an excess trimming over the cast, there will be a problem in our denture adaptation. A teeth has to be marked in the form of X, and alternative teeth has been marked in X, and in between these two X teeth we can mark it as a O. So this will be helpful for us while we are going for the trimming, and then this will be acting as a guide to determine their correct vertical position and inclination. Any space that remains between the modified cast and the anterior teeth on the denture is now filled with wax, and a complete flange is added. In the first picture A, the teeth alternative area, the teeth has been placed after removing the natural teeth with the help of the trimmers. And then in the picture B, you can see that already the artificial teeth has been placed, and then the in between teeth also has been removed, and then in the picture C, all the teeth which has to be replaced has been placed, and then picture D, all the area of the missing areas in the tooth structures and all these has been filled with the wax, and contouring has been done, and occlusion has been established in the last picture that you can see it. And next we have to go for wax contouring and flasking, that we have to proceed in the normal conventional method. And next is the surgical and immediate denture insertion after we are obtaining our dentures, and this is a processed and final denture we will obtain it. As the denture is obtained, we can call the patient for going for their immediate denture steps. Moving on to the next one is the surgical template. The surgical template is the most important one because it has to be done before we are packing our complete denture, that means in the laboratory work procedure. It is a thin transparent form which duplicates the tissue surface area of the immediate denture. It will be helpful if you are going for a surgical correction. As I have already mentioned, if the location or depth of the undercut is more than 2 mm, we are unable to do any other corrections. In that case, this surgical template will help us to go for a complete denture insertion. This, with the help of this surgical template, after the extraction, the surgeon will do any other modifications in their ridges, and the denture has been given on the day of their extraction itself. So what is the aftercare and the examination after 24 hours? Immediately after the insertion of the immediate denture, we are supposed to give instructions such that they are not supposed to remove their denture for 24 hours. So premature removal, if they are trying to remove the dentures, in the sense it is very difficult for them to reinsert by themselves. In that case, we have to give instructions that they are not supposed to remove their denture on that day. And the food which is recommended is soft or liquid diet. And the next 24 hours, the patient has to revisit us, and then we have to remove the denture. Only the doctor has supposed to remove the denture, and they have to irrigate with the warm saline. We have to check for any other tissue irritation area for the sore spots, or if it is present, we have to relieve it. And then we have to re-evaluate for the retention. And we have to prescribe a mouthwash, which we are supposed to ask the patient to go rinse for 3 to 4 times a day. And then we have to give a tissue conditioner if it is needed. If it is retention is compromised in that case we can give tissue conditioner. And after 24 hours of review, we have to call the patient after a week, and then if suture will be placed in case of interim immediate denture, in that case we have to go for a removal of the suture. And then in that case also we have to check for the tissue spots, that is any other sore spots is there, or any other irritation is there, or any other overextension of the denture is there. All these has to be evaluated. On that day also we have to remove all the irritated areas, and patient should be encouraged for a regular examination. And the further follow up is we have to ask the patient to come 2 weeks in between, and after that we can recall a patient after a month for the review. This is the normal protocol for it. And the references which have been given is, there are other modifications which have been given. In this I have quoted 3 to 4 references. In this, first one is a technique for enhancing cosmetics in immediate denture. This study has been done in the year of 1974. In this, the patient is reported to the department with extremely long teeth and gingival recession. In that case, they have immediately done a teeth replacement only with the help of the ligature wire, and then they have given a denture in the cold cure. And similarly, in second one, an alternative immediate complete denture, which an impression they have modified it. With the stock tray itself, they have just made an impression. In conventional immediate denture, they have done this procedure. And next is an one appointment construction of an immediate transitional complete denture using visible light cure resin. In this, the visible light cure is used. In this article, they have done this study for a physically compromised individuals, where they have given the dentures immediately and with the help of a visible light cure resin. And the fourth one is the trial anterior artificial tooth arrangement for an immediate denture patient. It's just a clinical report. They have done the denture with the help of a heat cure denture based resin, and the patient has been done with the anterior try-in, as it is the most important disadvantage that patient will not have an anterior wax try-in. They have just overcome it by doing a study over it. And moving on in detail about it, I am just doing a case presentation in this, where a patient has been reported with the missing of teeth in their upper and lower back teeth region for the past 2 months, and patient doesn't have any past medical history. In extraoral examination also, they don't have any facial asymmetry or no mandibular deviation during opening and closing their mouth, and mouth opening was 52 mm, it's normal. In intraoral examination also, they had teeth present from anteriors, and the upper anteriors was there, but upper posteriors was missing. In lower also, they had left quadrant posterior teeth were missing. And these are the teeth which had a grey mobility. The primary impression has been made and the master cast has been retrieved from that, and then we have done a posterior jaw relation where the denture base has been fabricated and the occlusal rims has been done over the denture bases. And then we have done a jaw relation with the patient, and then we have done a face bow transfer, and it has been transferred to the articulator. And posterior teeth arrangement has been done. In this case, as I have already mentioned, we have marked the teeth in X and O, as it is very easy for us to remember while you are doing a trimming and replacing our teeth. So the alternative removal of the teeth has been done and the teeth arrangement is done, and with the proper class 1 occlusion is obtained. After we have done our wax up, we have done certain modification in the cast to overcome the undercuts, and we have done a surgical template which will be helpful for the surgeon for them to analyze during their modifications of the undercuts. And then denture insertion has been given to the patient on the day of extraction itself, and then after 24 hours we have given a tissue conditioner for that. It will be supportive for the patient. And this is the picture which depicts the healing after a week. And this is the pre-operative and the post-operative photograph. So as to conclude, this immediate complete denture in the field of prosthodontics, it's mainly helpful in giving a patient by satisfying them psychologically and also mentally, and also it will be supportive for the patient to have their artificial teeth on the day of losing their natural teeth, which will enhance their aesthetics function, and it will be supportive for them. So these are the references. And thank you. Kindly watch this video.